Good morning, everybody, and welcome to SOC Virtual, which is really SOC Lockdown. We have 170 delegates that have registered, and I want to say thank you for your support. Thank you very much for attending. We have 5 rapid fire presentations today, and then we're going to have as many questions as we can from delegates. So please, if you go to your right hand side on the Zoom, you'll notice it's a message, and it either says message to everyone or message to Tech 1. If you keep it to message to everyone and type in questions there, we really have a timetable of 40 minutes for Q&A. So this is your opportunity to ask as many questions as you want in an interactive format. And there's no CET points to this. This is rapid fire. So really, we've got 5 fantastic presenters, and presenters I've known most of them for a long time. So I think you're going to have a great interactive morning on this Super Sunday of CET, followed by lunch, followed by sport. Of course, Scotland are playing France. The event SOC will now not take place till next year, really, with looking at the vaccination programme that's probably going to be put out. We think that next November, the 21st, will be the next date that really we can all get together, and I look forward to that very much. So I'd like to thank the sponsors today, platinum sponsor support from BMI, TEA, Topco, Keela, and Positive Impact, and I'll introduce each of the speakers as we go along. So really, without further ado, we'll move on to the first speaker. The first speaker is Sanjay Mantri. Sanjay Mantri is an ophthalmologist that's very pro-optometry. I think he's got a very good understanding of what optometrists can do. He has a specialist interest in cataract and refractive surgery, practicing now mainly privately at BMI Rossall Hospital, which is Eye Care Scotland, but doing some sessions at the Golden Jubilee as well, and Laser Vision Scotland. He did fellowships, one of them with Professor Heminder Dua, and that was in TDRI in Birmingham and Nottingham. So I'd like to welcome Sanjay to the meeting and to give the first presentation. Over to you, Sanjay.
Thank you, Scott. Can you hear me? All good?
Yes, I can hear you. If you speak as loud as you can, thank you.
Good morning, everyone, and thank you very much, Scott, for inviting me to give this virtual talk, The New Normal. And I think I just thought it's very topical at the moment to discuss about consenting for cataract surgery, the new normal way. And I think there are a few things which is very, very basic, and I think we all need to know. But from Scottish perspective, I think the model of shared care has never been better. And I think we have actually, in a way, the whole system of shared care is changing vastly, where actually the whole bit of the referral and post-op is done in the community, and it's very, very established. And hence, I think it's quite important that the whole process of any surgical procedure from ophthalmology point of view is done as a shared care. So without further ado, basically, I'm presenting on behalf of Eye Care Scotland. Luckily, the place which actually has whole range of eye care in a private setting. And I also work at Golden Jubilee. Have been doing cornea and refractive surgery for the last 15 years. And I just wanted to outline my talk by just saying what are the problems with elective work in the NHS in the current situation, some consent issues, which I think as a shared care, all of us should be involved in. And unfortunately, we will be all sort of liable for it. So it's worth knowing the whole process about it. And it's more important from Scottish perspective, I think, is because we are doing a shared care. So knowing between a routine versus a complex cataract and knowing the risk and complications is almost mandatory, not even optional. So it's quite important we little touch on that as well. So going on to the consent, I mean, it's very basic for any surgical procedure. The word consent actually derives from the principle of autonomy, of providing care. We traditionally, historically, went for Bolam principle. And I think a Bolam principle was a healthcare professional is not guilty if he acted in accordance to practice which was accepted by professionals who were peers. That's no longer valid in this day and age. And the landmark case was actually the 2015 Supreme Court judgment between Montgomery and Lanarkshire Health Board. Now, because of the time constraints, I'm not going to go into that, but what implications are there for cataract surgery are these, I would say. So since then, what we need to be telling the patients is any common and any serious complication that can happen with cataract surgery. So common being 1 in 20 risk of PCO, cystoid macular edema, 1 in 3,000 risk of infection or hemorrhage, which can potentially blind the eye, and other things that needs to be. Now, this is not one process. So serious complications, which can cause blindness, and common complications. The patients have to be given alternatives, i.e. conservative. So somebody who you're saying you cannot drive now because you've got cataract. Now they should have choices. You can have a surgical option. You can have a conservative option where they stop driving and they do not have cataract surgery. Alternatives should be given in terms of the lens choices. So me as a surgeon, I cannot sit in an NHS and say, these choices are not available. They should be given to them and say, these are the things which we can offer. Unilateral versus bilateral, we have to discuss this and give that choice to the patient. So those are the outlines of Montgomery principles that we have to tell them common and serious complications. We all have to tell them all alternatives that's available. And patient needs to be informed about in terms of giving them patient information at the time of referral and enough cooling down period after consent, after the consultation is done. So there is a lot more involved, which should be our pathway anyway. However, since Montgomery, you can be liable if you've not adhered to that. One of the things which has come out significant joint consultation between Royal College and UKISCRIS, which is the national body for cataract and refractive surgery. We are facing a significant capacity challenge now. The NHS elective work for cataract surgery is postponed and delayed because of the redeployment of the staff to the COVID wards. And effectively, this is nothing new. COVID, NICE guidelines 2017 said we should be offering unilateral versus bilateral, but it's more important under this scenario where, for example, I'll give you an example. A typical 80-year-old with COPD comes to your clinic and has visual acuity of 624 versus 618 in both eyes. You planning to do both eyes. Now, the risk of 0.00012% risk of bilateral endophthalmitis really outweighs the risk of somebody catching a COVID with 5 hospital visits in this scenario. So this is something which has been looked at very, very, very carefully, and the case selection is very, very stringent. Hence, we've actually at Golden Jubilee now offered this as a pathway too. Now, I still think the take up at the moment is only 13%. However, I'm not saying everybody will be very stringent in that criteria. And I was the only one who would not offer bilateral surgery before. But I think under the circumstances for a shorter period, at least till the vaccine is available and we are back to normality, this is a new process of consenting, and we should be offering it to the patients. So as a part of Montgomery principle, we have to offer this to patients. Not everyone is suitable for it. If it's a complex one, and there's a huge amount of big list that we go through about that. I wanted to touch on complex cataract surgery versus routine, and the complex ones, particularly for example, if somebody is very long-sighted, has a narrow angle, and has very small space to work in the eye, that's got much more risk than a straightforward cataract. A high myopia has definitely increased risk of PC rupture and retinal detachment, so has to be put into perspective. Pseudoexfoliation, mature cataract, small pupils, people on various other medications or difficult access, these have to be now looked into in a different perspective. So it's quite important that we engage with and know what's the routine and what is a complex cataract. So I just wanted to give you a couple of examples, and I know time limiting, I've actually got the video to be. So this is a typical femto cataract, which I would offer at Eye Care Scotland. Now, everybody is not suitable for it, but just to say how simple, what we're doing here is docking on the eye, and effectively we are doing, you've got antersegment OCT, which actually is now creating a capsulorhexis, fragmentation, and corneal incision. And effectively, you are doing that and then taking it to the microscope and opening the incision, just putting viscoelastic in the eye, and effectively just already the capsulorhexis is done for you. You take the capsulorhexis, very important in high hyperopes and high myopes, and you use ultrasound to take the lens out, and then you are taking the lens out and putting a lens implant in. Now it's fast forwarded, so hopefully it's not as rough as that ever. And we are putting the lens implant in, a toric lens implant in this case. So fairly straightforward and surgery. This contrasts to, so this is a straightforward 20-minute cataract surgery. Now this contrasts to this. Look at this, a 29-year-old diabetic who's now got a mature cataract, and it's a bag which is swollen. And the minute you do, I have a flag sign on the top called Argentinian flag sign. So just look at this. I have no access to see how I will do a capsulorhexis. So when I do this, I am actually using a vision blue to make, but what my aim here is actually what I'm trying to do here is make a little neck and then do a capsulorhexis, which is a round capsulorhexis. But just watch what happens. Oh, so sorry, I had to play that again. But effectively, the minute you touch the eye, because it's a swollen bag, just see how it goes. And this is typical Argentinian flag sign. So this capsule will go behind and the lens will drop at the back of the eye. A retinal surgeon will have to pick it up. So this is such a simple, if this patient was referred earlier, we could have actually had a very straightforward surgery. Luckily, this patient did well. However, this could have been a very complicated case. We all need to be aware of PC rupture and vitreous loss as a complication, and it's very inversely proportional to the experience. So it is almost as much as 1 in 20 in a trainee to 1 in 500 to people who do high volume cataract surgery doing at least 30 to 40 a week. And obviously risk of zonular loss, dropped nucleus, and floppy iris syndrome with tamsulosin. The most devastating complication that can ever happen after a cataract surgery is endophthalmitis, which is why I never was keen on bilateral ever. But the risk, we used to quote that as a 1 in 1,000, but luckily now it's 1 in 3,000 with intraoperative antibiotics and postoperatively broad spectrum antibiotics. The risks like corneal edema, wound leak, lens matter, retained lens matter, uveitis are the common ones. But most devastating one is 1 in 3,000 risk of infection. Now, this is one case where if somebody has got good vision and suddenly has a lid swelling, painful eye, and you see hypopyon in the eye, that's one emergency where I would go in the middle of the night to give the injection, because overnight it can just change to a bag of pus and total blindness. So it's quite important that this is acted upon when we are doing a joint care, and we need to be all aware and have access to each other. Late complications, the two more important ones is PCO, which is again can be common as early as 6 months to up to 20 years. And a simple YAG laser treatment will help. Cystoid macular edema is quite interesting because when they get discharged, they've got good vision. You're talking of 6.6 or 6.9 and then patient comes to you at 4 weeks time. A timing of cystoid macular edema is typically between 3 to 5 weeks, and that's when they're visiting you post-operatively. And with us having access to OCT, actually you'll find a lot more cystoid macular edema. And luckily with the IP, you will be able to give them a combination rather than sending them back. You could actually restart the Pred Forte and non-steroidal, which is Acular or Nevenac, with or without Diamox. Now, I suppose Diamox, you'll have to get them back to the hospital, but otherwise they respond very well with this combination. Just a couple of cases before I go, but just to give you bring home the importance of early referral in some cases. Now, this patient was referred with cataract because they could not drive, 618, seen by a junior, seen in NHS hospital, booked to a waiting list cataract surgery. Waiting list consultant came from somewhere else, did the surgery, very routine surgery, but actually Fuchs endothelial dystrophy was missed, which was moderate to advanced. And if you see the picture on the right-hand corner, at the bottom, the cornea decompensated, and 9 months later, the patient needed a corneal graft, which then brought him back to 6'9". But we could have avoided this being an early referral and early recognition of this Fuchs endothelial dystrophy. Another case where early recognition is quite important is narrow angles. And it's quite important. If you've got a +8 or +6 or a high hyperope in your practice, and the first time you think, I'm not comfortable dilating this patient, that's when you start thinking, should I refer for a YAG-PI? Should I think of an early cataract? Because once they get into the realms of subacute angle closure or angle closure, actually, it's a very, very different story. I'll give you an example of this gentleman who was 6'5" before, was noted to have early cataract, but was not causing him problem. He's 6'5". He presented with angle closure glaucoma in one eye. He had a YAG-PI, did not respond very well with that, and the lens had swollen. And effectively, when I did the cataract surgery, there was no space in the eye. So I told the patient, unfortunately, it does seem that the cornea will decompensate, and it did. So the patient needed an endothelial transplant and then did very well a year later. But we elected to do the left eye, which is again 6'5", but actually IOP was controlled and did really well, but didn't need a graft. So quite important that we need to recognize Fuchs endothelial dystrophy and narrow angles. So just to summarize, I think the new normal, where we have to give choices to the patients, we have to keep them informed at every stage, and hopefully the shared care responsibility leads us to have a better patient care, but medico-legally, we're all bound by giving them all the information about surgery, all the choices, and discussing them with them, the standard risk or complications versus serious sight-threatening ones, and early recognition and referral necessary in situations like narrow angles and Fuchs endothelial dystrophy. Many thanks.
That was fantastic, Sanjay. Thank you so much. And there we go. Can you hear me, Sanjay? Oh.
Sanjay, just check your speakers aren't muted.
There we go. So thank you very much, Sanjay, for that. That was a succinct presentation and some really interesting points, especially with the bilateral surgery. And as I see some questions coming in, and I would just remind people, please keep asking questions because we will get round to that next. Can everybody hear me okay? Yep. So, yep. Right, without further ado, we're moving on with a rapid fire, and it's very welcome of me to introduce you to Nick Rumney. We're moving on to we've moved on to Mina's presentation. Let's move on to Mina. Sorry, I think it was the running order has been slightly changed there. With Mina Poor, Mina is a sales and education lead for TEA UK, and both a qualified optometrist and dispensing optician. So previously working in soft lawn and Cooper Vision, and professional services manager for Leighton's and a fellow of the BCLA. So without further ado, I'd like to very much welcome Mina Poor. Can you hear me okay, Mina?
Yes, good morning, Scott. So
Welcome.
welcome everybody. My name's Mina, and as Scott mentioned, I'm an optometrist and sales and education lead. I'm just going to pass over to my colleague Wendy, so she's just going to do a quick intro before I talk about products.
Thanks, Mina. Thanks, Scott, for inviting us along today to present. And I would just like to say on behalf of Tia, a warm welcome to everybody, and I look forward to seeing you all in person next year. As an introduction, I'm Wendy and I'm the area sales representative for Scotland, and I'm joined with my professional services colleague today, Mina Poor. Next slide, please, Mina. I'd like to start really just be giving a brief history on TA Laboratoires to give some insight into the values, ethos and culture of the company. It is of a French family heritage, the Chibray family, and they've been actively dedicated to ophthalmology for over 150 years. As it's evolved, we're now into the 5th generation of the family, and they're still actively involved in the day-to-day running of the business. There has always been and continues to be a focus on education and support and of research and development of preservative-free, innovative solutions to meet unmet healthcare professional needs. Next slide, please, Mina. Through this evolution, there's always been a humanitarian involvement, and it traces right back to first generation Paul Chibray from the family, who was an ophthalmologist in 1870, and his fight to tackle trachoma in developing countries. This led to the inception and development of the TIA Foundation in 2012, which continues this charitable cause today. Next slide, please. So TIA in the UK today, they were one of the first companies to bring in preservative-free eye drops to the market. And in the UK, we've been here for 12 years and we're made up of 3 distinct business units. The first one is the surgical business unit, which focuses on innovative medicines used in cataract replacement. So we've got some, you might be aware of Apricam and some Midriatic products. We also have a medical business unit, which deals wholly with the prescription only side of the business. So again, you might be aware of and have heard of products like Dexafree, Monopost, Tiapex, to name but a few. And last but not least, we have the third part of the structure, which is the eye health team. And that focuses purely on optometry and pharmacy. And that will be the products that you're familiar with in your day-to-day running of your business. I'm going to hand over to Mina, who's going to cover off where we are today with the products in a bit more detail.
Thank you. Thank you very much, Wendy, and thank you, Scott, for the introduction. Oh, my slides seem to have, oh, here we go. So before I talk about the product range, I'm going to actually talk about the importance of eyelid cleansing. So there we go. Sorry, my screen was a bit slow. So as an optometrist, I think for me, when I do the dry eye routine, I always think about eyelids first. So it was almost like my step one. And it's really important that we check the eyelids for anterior and posterior blepharitis, because one of the main reasons patients experience dry eye is inflammation of the eyelids. And you can see a study referenced along the bottom there, which mentions that over 80% of the patients who complain of dry eye have inflamed eyelids, which not only need eyelid care, but also lubricating eye drops, which is usually the step 2. So what products would I recommend? Now, for eyelid cleaning, we have a fantastic range of products. BlephaClean is clinically proven for the management of blepharitis and actually can be used in babies from 3 months. They are sterile wipes which contain micellar. And again, along the bottom there, we've got a reference which actually showed that when you use BlephaClean for 21 days, twice daily, you get significant improvements in the eyelids, you get less blockage of the glands, reduced dry eye symptoms, and also improved comfort. And you saw from Sanjay's slides as well that I always recommend BlephaClean pre and post cataract surgery as well. So for me, BlephaClean is the gold standard. And if I then want to move to more a long-term solution and a cost-effective option, I tend to talk about Blephasol. Blephagel I tend to sort of recommend for patients that have got really crusty eyelids, and especially for those patients that really want that cooling effect on those inflamed eyelids, and also for your elderly patients. Not to forget, we've also got Blephademidex as part of the Blepha range. So that's, as you can see, it says it on the box, is for the relief of symptoms of eyelid inflammation, which is naturally caused by the Demodex mites. Now, it contains terpene and phorol, and that's the most abundant ingredient within tea tree oil. The Demodex mites have a life cycle of about 3 weeks. So I would recommend this product for 1 full cycle, a little bit longer because we've got 30 wipes in there. So I would recommend that the patient uses it daily at night, because that's when the Demodex mites are most active. And thereon after, I would recommend that they continue with some form of maintenance on their eyelids, such as, Blephaclean or Blephasol. The top tip as an optometrist to detect Demodex mites, the most pathognomic finding is the cylindrical dandruff, and to check it at really high magnifications on your slit lamp. So you need at least 25 to about 40 times. Now, I'm going to move on to the step 2 process. So once I've recommended eyelid cleansing for my patients, I then move on to lubricating eye drops. So Hyabac is our 2nd generation eye drop. It contains hyaluronic acid. So we know hyaluronic acid is a remarkable compound, is found naturally in the body, but the reason why it's so unique, it is highly moisturizing and mimics the tear film. The other thing is preservative free. For those of you that have read the TFOS Juice 2 report, it mentions that preservatives are not great for the ocular surface. So when you're moving your patients from preserved solutions, such as hypermellows, to non-preserved, this is a great way to transition them through, because it is cost effective and it's really good for those occasional dry eye wearers. And not to forget, contact lens wearers can incorporate this as well in their routine. So that was our 2nd generation eye drop. The 3rd generation, Telos Duo. So for those of you that don't know the difference, this contains hyaluronic acid, so same thing as Hyabac, but it's got that unique formulation of trehalose. So what trehalose is, again, I'm going to refer to TFOS Juice 2, which mentions that if you incorporate an osmoprotectant within the eye drops, it does protect the corneal cells. So that's why we've got this generation 3 eye drop. Not to forget, it's an easy to squeeze bottle, so I'm hoping you can see that, but it's really easy to squeeze. And the reason why that's so good is for those patients that have got dexterity or arthritis issues. And also 50% of patients struggle to aim and squeeze. So this is really good for that. But what I like about the bottle is that you can rest it on the bridge of your nose and actually still squeeze drops out. So the bottle doesn't need to always be vertical. You can still take you can see the solution coming out there. Again, suitable for contact lens wearers. And I put in there viscosity is not always the answer, because when you put in a solution which is more viscous in the eye simply results in reflex blinking and tearing, because it wants to regain that original viscosity in the eye. So for me, a good eye drop means that it needs good wettability, it needs to spread over the ocular surface, and it needs to have long-lasting properties. The other thing I like about the bottle, which I didn't come back to, is it's got 300 drops in here, which are all calibrated. They're all to the measured dose, so there's no wastage. So that's really good for your patients. Now, long lasting, this for me it's really beneficial for those patients that come in and say, I have to keep reapplying my eye drops. So Telos Duo, this is research, evidence-based, mentions that it lasts up to 4 hours after application. So what this graph is showing, the blue is actually sodium hyaluronate and the green is Telos Duo. So as soon as you put these drops in, so you can see you pop them in and suddenly there's an increase in the tear film thickness. So over the course of the day, you can see sodium hyaluronate starts deteriorating quite quickly. So it only stays on the tear film for about 40 minutes, whereas Telos Duo will carry on and it will remain on the surface for 4 hours. And I've already mentioned the unique formulation and the ABAC system of the bottle. So we've got some really good news with Taylor's Duo. We have actually got a TV national campaign, which will be ending on the 29th of November. And this is really to increase that awareness of Taylor's Duo with your patients. And this can be seen on ITV3 nationwide. And lastly, Nutrof Total. This is another thing that I recommend, especially to my dry eye patients, my macular degeneration patients, but generally for those patients that you're talking to about eye health and diet and lifestyle. The Teya Nutrof Total contains carotenoids, which we've all heard about in macular degeneration. It contains omega-3, so which is great for your dry eye patients. And also vitamin D, especially I think we're hearing a lot more now, it's very topical. So this contains vitamin D and other vitamins such as resveratrol. But again, speak to myself or Wendy, email us and we can talk to you a little bit more about these products. But another thing I just wanted to add in is the mask-associated dry eye. This is really important now that we're made aware of this, because a lot of our patients are wearing masks now, or a lot of us are wearing masks. And if not fitted correctly, the air from the breathing is actually channeled upwards, and this causes the eyes to evaporate. So when Core did this study, it mentioned what solutions we can talk to our patients about, such as making sure that mask is tightly fitted across the top of the nose, but also lubricating eye drops is a definite way that eye care practitioners can do that recommendation. So the last slide from me is the future. So how can we help you? You can see there we do a number of webinars. These are free webinars, and we're going to continue doing them next year. We have got a portfolio of CET programs, and also we can help set up dry eye clinics. So if any of these you're interested in, please get in touch. And because education has always been at the forefront of Teya Pharmaceuticals, but also, as Wendy mentioned, for the future, Teya will continue to innovate and put customers first in terms of delivering OTC, medical, and surgical products. So I hope you found that useful. Thank you very much, and we look forward to answering any questions later on. Thank you.
That was lovely, and thank you very much for that. The very succinct talk, and I could see some questions coming up, and quite a lot of people asking about the Demodex as well, blepharitis. We'll have questions on that later. So again, without further ado, because it's rapid fire, we're going to move on to our next presenter, Nick Atkins. Now, Nick is a DO and CLO, and has a various number of roles in the optical industry, as well as working as professional services manager, working for B&L, past president of the BCLA, an avid football supporter, as we heard earlier as well, but now is director of marketing for Positive Impact. And I'm delighted to welcome Nick, and I'm sure a lot of you will have heard Nick before. So Nick, welcome, and I'm looking forward to your presentation.
Thanks, Scott. I trust everyone can see my slides.
Yes, we're on.
Perfect. Thank you. So to continue a theme, thanks to Mina for doing a lot of my job for me as far as dry eye is concerned. My company, Positive Impact, now has developed quite a portfolio of dry eye products. And really, I just wanted to take this opportunity to introduce you to a lot of them. For those of you that might be aware of some of them or none of them, it's an opportunity for us to introduce you. And my first slide really is just the only one that's probably significantly educational. And I'm sure the group that I'm talking to are very familiar with the JEWS 2 dry eye definition. And one of the reasons that I put it up here really is to highlight three words: that it's a multifactorial disease, and ultimately there's hyperosmolarity going on and ocular surface inflammation. And the reason I mention that is I believe that we are now the only company in the UK that really can help practitioners with all these aspects, both from a diagnosis and a treatment option. So back in 2015, I think it was, we became the exclusive distributor in the UK for the Inflamadry test, and more recently we're now collaborating with TearLab, and anyone that owns a TearLab or is interested in owning a TearLab will need to talk to Positive Impact in that regard. So we actually have what I consider to be the gold standard, if you like, for testing. I'm very mindful of the fact in this current pandemic, there's been a phrase often used, test, test, test. And I must admit to being somewhat frustrated by the fact that most practitioners still, while they do a gamut of tests, the accuracy and sensitivity and specificity of those tests are pretty poor for dry eye. And I think these two tests, certainly based on the Jews report, are the sort of tests we should be doing for our patients to really rule in, or for that matter, just as importantly, to rule out dry eye as a cause of the patient's symptoms. So we've been offered a number of products over the years, and being a distributor, it's given us an opportunity to build what, as I say, we consider a best-in-class portfolio, sort of cherry picking, if you like, products that are available from around the world, from Europe and the USA. These two products, of course, are American, and bring them into our portfolio. Just coming on to that point, just this slide really just shows the difference between a lot of testing in as far as sensitivity and specificity. And you can see that Inflamadry and TearLab tear osmolarity system are far more accurate ultimately in getting you a diagnosis of whether the patient has or doesn't have dry eye. And if the ocular surface, to Mina's point, in a lot of lid conditions are inflamed, you can again confirm if there's a level of inflammation, and that may well influence your ultimate management of the patient. From here, I just want to talk about the rest of our portfolio. Really is around managing the dry eye. And of course, often the first core route for practitioners, and particularly practitioners that perhaps aren't so into dry eye management, haven't got a specific clinic or kit to manage their dry eye patient. Of course, drops tend to be the first line of defense. But we started, in fact, with punctum plugs, and we have a solution now developed by Craig Wilcox, who's an independent optometrist down in Dorset, who's developed a really interesting formulation for eyelid hygiene. We have tapped into a product from Northern Ireland, in fact, developed by Professor Johnny Moore, that is a unique omega supplementation for dry eyes. Most recently, we've become the exclusive UK distributor for what I believe is by far and away the best eye compress on the market, and I'll come on to that later, and also the range of products that are available from the eye doctor. Probably our main product, though, and that's the one I'm going to start with, is Hydromed. And Hydromed is an interesting, to use Mina's language, third generation eye drop product. And recently we just launched Hydromed Forte, which is a modification of the original Hydromed for more moderate to severe dry eye rather than just dry eye alone. So we slightly tongue-in-cheek do talk about Hydromed being the only drops you'll ever need. To give you an overview of the formulation, as Mina's covered off, HA was, if you like, the second generation and became very quickly the gold standard. It's important to always remember that when you use HA, it has to be long molecular chain, HA, high molecular weight, to actually have best effect. But most of the third generation products now are using something else. It is not just about HA. HA has took us to another level, but actually incorporating other things like trehalose. In our case, it's tamarind seed polysaccharide. Some of you may be familiar with this. It's a unique active that was developed by Pharmagea, who produce Hydromed. And tamarind seed polysaccharide has the unique benefit of being a mucomimetic. In fact, if you look at the branch chain structure, and that's one of the key differences between HA, which is a kind of long chain molecule, TSP is a branch chain structure, very, very similar to mucin 1 at the ocular surface. And so it helps to, if you like, bind keep the drop working and repairing the ocular surface. In fact, we generally find there's about a 50% improvement in epithelial microvilli versus a 0.2 HA solution. And generally there's a reduction in epithelial damage and stinging, etc., using in studies that have been using the Hydromed formulation. Absolutely essential, of course, is that there are no preservatives, particularly for use post-surgery, that there are no phosphates, which have been known to cause corneal opacification, and other sensitizers or parabens in the solution. Interestingly, Hydromed uses water for injection as the basis of the solution, and it's one of the few drops that actually use this highest quality of water in the production of the drop. And as you can see here, it comes in two formats: a 10 ml bottle and preservative-free bottle, and a resealable unit dose. That's probably one of the key features of this unit dose, is that you can take these tops off and you can replace them so the patient can use. There's probably a good 10 to 12 drops in each one of these vials that can be used throughout the day. And as I mentioned, we've just recently introduced 0.4% HA with 0.2% TSP. So a doubling of the HA concentration, which interestingly increases the viscosity, which is known to increase retention times. One of the key things, despite having 4 times the viscosity of Hydromed itself, is it's still, it doesn't significantly blur the vision because of the non-Newtonian behavior. I'm not going to go into great detail about non-Newtonian behavior, but the tears display it. They thicken up between blinks and they reduce in viscosity during blink, and exactly the behavior of the Hydromed solution. So despite being thicker and improving retention times, it doesn't cause the problems of blurring. So there's a quick features and benefits slide, which I'm not sure I'm going to have time to take you through. But fundamentally, the features: HATSP, it's a hypertonic solution to immediately try and get isotonicity into the tear film, uses a citrate buffer, not phosphate, and it's preservative free. The other key thing that we developed during lockdown is a way for you to recommend your patients. Of course, in these current lockdowns, patients have challenges maybe getting into practices, despite the fact that we are open. With most practices are very busy now. And this website enables you to recommend your patients go and buy their Hydromed if they can't get into the practice, but we share a rebate with the practice via a unique code. And if you want more information about that, either visit hydromed.shop or contact me or Positive Impact after the lecture, and we'll talk to you about how you can still enable your patients to buy online without losing revenue. I mentioned before that the key thing that was missing from our range until very, very recently, and we were looking at some options. In fact, at last year's conference, we introduced a mask to some delegates, which we've decided not to proceed with, because fundamentally we discovered that actually there's a superior product that has been long available here in the UK from the eye doctor. And I'll just touch on a few key features of the eye doctor compress. One of the key things is it has a unique, you see the blue fabric on the image here. Those of you that can see me, big enough. You'll see this blue fabric is actually antibacterial fabric now. So when you're putting this mask regularly onto eyes that have all sorts of staph epidermidis and staph aureus and pseudomonas on the eyelids, you can be safe in the knowledge that they're not accumulating in volume and numbers on the surface of the compress. It also uses body beads, silica beads, to deliver a moist heat. Moist heat is very important in giving penetrative. It's far more penetrative than dry heat. So this is a no seeds or grains bag. It actually generates a moist heat, and there's studies that show it meets the temperature for the right period of time. You've probably read all the other benefits there, and this is one of the key slides that I wanted to share with you. Apologies, it's not the clearest slide in the world. But what you can see here, this was a study done in the University of Montreal, and it was published in Clay. And this shows a range of masks and how they get quickly to temperature. And interestingly, they were comparing it with a face cloth. What you can see is there are only 3 bags that really got, the green zone is where you want to be. You don't want to be too hot because you could potentially burn the very sensitive tissues of the eyelids. So we actually have the eye doctor and the eye bag being the 2 products, if you like, routinely available in the UK, that actually one got to the required temperature and maintained that temperature for the right period of time. So you can be confident that with this product, you're getting the level of heat that you need in order to clear the lids. I mentioned earlier Demex. Demex is a foam solution that is for lid care. It was developed by an optometrist to just use in his practice, actually, Craig Wilcox. And Craig uses T4 that Mina mentioned, which is the key active in tea tree oil. Tea tree oil itself has got lots of nasty toxic things in it and should never be used anywhere near the eyelids. But the key active that is effective in killing Demodex, T40, is what is needed. And Demex is a foaming solution rather than the less environmentally friendly lid wipe type option that you can apply to the eyelids. And we recommend just literally digital application of the foam. And this is a picture from one of Craig's patients, the typical collarette type dandruff that you see with Demodex, and then after regular use with the Demex product. It's interesting, one of the themes of these kind of presentations often is when we talk about HA. I mentioned that HA, there's HA and there's HA. There's very short chain, low molecular weight, and then what you really need is to be using high molecular weight, long chain molecules. And there's a very similar thing in the sort of omega-3 area as well. And this product was developed, as I say, by Professor Johnny Moore over at Cathedral Eye Clinic in Northern Ireland, in Belfast. And we're the distributors for it in the UK. And it's a very interesting product in that at first glance, it uses a lot less active omega-3. But the key thing about it is the quality of the omega-3. This is natural oil that has become from small fish, and such as anchovies and the like. And as a result, it's also not concentrated or chemically affected in any way, shape or form. It literally comes out of, it's distilled from the fish and put into either a liquid format or into a capsule format. And one of the key things that we find with this particular product, the one thing, in fact, the option I use every day is the liquid. The liquid is twice the strength of the capsules, and it doesn't have any unpleasant fishy smell or taste. In fact, the smell generally that you get from omega-3 type products means the product is breaking down. It's not as pure, it's not as native as it was when it came out of the sea, if you like, or out of the animal. And that's what causes the smell. So the fact this product doesn't have that smell because it's very pure. In fact, there's also some lemon oil and virgin olive oil in there. And it is just like having a high quality oil, and you can put it in your cereal or in your orange juice. I take it just off a spoon, and it's a very pleasant oil to take, and has very high therapeutic levels of omega-3. Interestingly, the other key thing is if you do go for the blister packed option, we use fish gelatin rather than animal gelatin. So though people who can't, for whatever reason, have bovine or meat-based gelatin, this is a product for them. And finally, I think just to wrap things up, coming soon, a really interesting product, new lids. I'm going to be introducing new lids in my 5-minute slot on Tuesday on the Tech Bites run by 100% Optical, which is Tuesday night at 7:30 to 8:30. But new lids, as you can probably see and gather from the pictures, is an eyelid cleaning device that is going to be available for both in practice professional use, but one of the unique features is it's safe and effective for patients to use on their eyelids at home to get a more effective, to improve compliance and actually get a more effective clean of the eyelids every day via the device. So that's me done. Thank you very much for your time. If you want to find out more about our products, visit the positiveimpact.co.uk website, or simply email me at nick@positiveimpact.co.uk. Thank you.
Well, Nick, thank you so much for that. That's a plethora of products. Fantastic. And I can see questions coming in already. And I would also invite you to go to that Tech Big talk that Nick was talking about. So thank you so much. And thank you for everybody so far keeping the time. That's right bang on time. So really moving ahead at speed, I'm now going to introduce my next speaker, who is Professor Nick Rumney. Now, Nick is chairman of BBR Optometry and award-winning practice down in England. He's also recently got a visiting professor post, University of Manchester, I think an MSc course there. Also very much involved with ECO, with the European scene in optometry. And his specialist interest as an IP community optometrist, but also low vision is a big interest of him. So without further ado, as a TopCon consultant as well, I'd like him to talk about Harmony. Nick, you're very welcome. Thank you.
Okay, so we should be sharing the screen there, and let's have a look.
Got just part of your screen, Nick. There we
Got
go.
it?
Yep, you're okay.
Okay, so what you might not know or might not remember is that today is a very, very famous day in history because it's November the 22nd. Most people of a certain age can remember where they were, but probably very few that are listening in. It's actually even more famous for another event. And I just want to rub this into my colleagues up a little bit north of the border there. Okay, so let's take you through TopCon. TopCon Healthcare Solutions is a subsidiary. Most people will know TopCon as a comprehensive ophthalmic device manufacturer. Long history going back over 85 years. They were actually one of the very first camera manufacturers to produce through the lens metering, going back into the early 60s, predating Nikon and Canon, and in the early 60s they were ahead of the game. It's now started to look with a change in management in TopCon Global, started to look a lot more at its software solutions. And in order to do this, TopCon has sourced different software manufacturers, and they're using a company based out of Finland, a company in a city called Oulu. It's about 200 kilometers north of Helsinki. For those of you who can remember the early days of mobile phone technology, Finland is certainly one of the places that leads the world in software development. So what's happened? They've created a product called Harmony, and that's what we're going to talk about. But why would we want to talk about that? Well, a little bit following on from Sanjay's talk, there is a lot of public concern about vision and vision problems, and this has not been made any easier, perhaps by COVID. So we've got glaucoma as a world's leading cause of irreversible blindness, 22 patients a month suffering severe or permanent loss. And then just a couple of years ago, there was a payout to a 34-year-old woman who lost sight due to delays in seeing specialists over 11 months. So goodness knows what we've stored up in the last 12 months. So she was referred in 2016, saw 7 ophthalmologists, laser was delayed, etc., etc. That led to Health Safety Investigation Branch looking at devastating impact of delays and the pressure on national glaucoma services. And I'm focusing on glaucoma particularly as we lead into discussing Harmony. So there's inadequate capacity to follow up within the hospital sector, and yet there's going to be a 44% increase in glaucoma by 2035. Now, that might just time with the fact that we won't be able to drive cars anymore. We'll be on electric self-driving cars, so maybe it won't matter so much, but that's just being a little bit glib. There is a hugely risk-averse culture, and this risk-averse culture exists both in optometry in terms of referring patients in who may or may not be at risk of developing glaucoma, but it also exists within the hospital sector, where basically once you're in the system, you're in the system, and there's a very risk-averse culture about discharging patients with glaucoma. So greater priority tends to be given to those who've been seen rather than new referrals. There's been a response from the college, and the Royal College of Ophthalmologists was very involved with a GIRFT program, the Getting It Right First Time. So this assumes that looking at 3 most common sight-threatening conditions, you should improve referral and discharge procedures, ensure that patients seen efficiently at the appropriate time by the most appropriate professional, use resources across the entire specialty, but individual solutions vary, okay? And I think you could probably say that the COVID crisis has pushed optometry further up the agenda into working with this. So how do we go about improving referral and discharge processes, and how do we use resources across the entire specialty? Well, one of the obvious ways is to start thinking about how we might communicate better. And that's essentially what Harmony is. It's a common platform for communication between primary care and secondary care using a cloud-based system. So you have data management, you have communication management, workflow management. So you have collection of data, assembly of data in one place. You can communicate that in terms of a referral, or perhaps what we've been doing a lot of in our area is collecting the data, talking to the ophthalmologist, asking them whether they want to see that patient or not, and then making up a workflow so that we get two-way communication, leading to a much higher quality outcome. So it's putting it all in one place. So I'll just ask you a little bit of a quiz. Does anybody here know what DICOM means? DICOM is something that is fundamentally at the heart of Harmony. DICOM is Digital Imaging and Communications in Medicine. It is a standard format for the communication management of medical imaging. If you have an Optos, or if you have an OCT, whether it's Topcon or Heidelberg or whoever, then it will be producing its data apart from the simple screenshot JPEGs and PNG files, which are just standard image files. It will be producing DICOM files. It's been widely adopted by hospitals. It's making small inroads now into other applications. DICOM files can be exchanged, and the critical thing is that they're dynamic. So you're probably all familiar with the OCT B scans, where you actually play a video of a series of 200 maybe scans horizontally through the retina as it forms its cube of data. Well, if you're just sending a single scan JPEG shot of a photograph across to your local ophthalmologist, that may not give them enough information. But you don't want to send them the entire the entire OCT file, which may be very big and clog up the network. A DICOM file actually enables you to send that video, and it's dynamic. But it comes from the American College of Radiology and the National Electrical Manufacturers Association, so it's gradually feeding across towards us. It's been around since '83, so it's surprising we haven't heard of it up to now. So effectively what we have with Harmony is a centralized archive, all document data stored in DICOM. It's a universal web-based viewer, so it's basically cloud-based and accessed through a high level of security. It allows you to tailor your examination communication reports. You can very much easily customize those. It's got a tailored user interface, and then you've got statistical reports and dashboards integrating with your electronic medical record or your practice management system. You'd have examination device integrations, and I'll show you that in just a moment. But you can also import historical data from examination devices. So if you've got an older OCT, older fundus camera, etc., obviously it can be you can be trained. So here we go. It's data management, telemedicine, and unlimited connectivity. So here, sitting at the top, there is this turnkey solution. You might have your visual field analyzer, topographer, slit lamp, fundus camera, etc., etc. It links in through Harmony, and then you've got the capability of having flexible viewing, remote consultations, analysis, and this can be dealt with at either a public hospital level or private healthcare. You access all of your data from any place at any time. And in terms of a workflow example, you might have a patient registered to your electronic medical record in your optometry practice. Harmony can distribute that. You produce the examination, and the data is automatically transferred to Harmony. You can then send, if you want to, you could send out to artificial intelligence-based image analysis. You could have review from the ophthalmologist, optometrist, optician, reviewing the data and deciding on whether consultation is necessary. Consulting ophthalmologist can review the data, replies, very much always a bone of contention on the optometry ophthalmology interface, and then referral back to the eye care provider, and the sender of the signal gets the diagnosis, recommendations, follow-ups, instructions. And this doesn't take very long to do. And this is a typical universal viewer. You can see here we've got a montage fundus photograph. We've got 2 visual field plots. We've got a slit lamp camera. We've got an Optos view, and we've got an OCT. And as I said, that OCT is a dynamic file. You can see the little video bar at the bottom indicating that you could look at all of those scans, not just a single JPEG shot. Typically here we've got another set of OCT images, and the system here is showing that it's compatible with both Topcon Triton, Nidec, and Heidelberg, so all capable. So a typical pathway might be, and this is what we're living with at the moment, you attend the optometrist, you have a sight test, you refer to the GP, refer to the HES, paper referrals scanned in, referrals reviewed by the consultant. Pretty much all patients are offered an appointment. Very few patients get turned down at that point. They get clerked in, they get some tests repeated, lots of tests repeated. Often the testing process is not treated with a great deal of consistency at that point, and a whole series of decisions get made. But a written referral, now we can see them, is highly variable, exacerbated by high numbers of locum optometrists. Who knows who's accredited to what scheme? We don't get a full data set. Not all instruments are compatible. And the culture is very much, we get a pat on the back for referring, but who's paying for that? The GP doesn't add any value, usually. There's a variable quality of data. It's not actually triaged at that point. Very few referrals are sent back. Does everybody need a face-to-face consultant? And then all of the optometrist tests are often repeated. So the HES, highly risk averse to discharge, you end up with lifetime follow-up, particularly for glaucoma patients. So 0 feedback, and the next time they turn up at another optometrist, they re-refer. So this is not a really good pathway. But an integrated pathway, you'd have them attending an accredited optometrist who would do the examination and repeat tests as necessary. GP gets copied in, can offer data if they want to. Patients referred to the HES, referrals viewed on Harmony, remote referral viewed, referral back to the optometrist, off to the clinic, follow up in the community if it's ocular hypertension, for example, and long-term monitoring takes place differently. So you might end up returning for repeat tests. The whole thing is much more integrated, and Harmony would help that. You'd have a minimum standard of equipment, and I do believe with across the UK, it rather looks like Scotland and Northern Ireland have moved much further in that direction. Optometrists have to be better at making decisions and diagnosing, and that's kind of the feedback will help with that. So the idea is to avoid getting patients into outpatients in the first place if you possibly can. And that's why we would say you should be joining eHarmony if you're an optometrist and you're looking for a digital solution. That's Topcon Healthcare, seeing things slightly differently. Thank you, Scott.
That's lovely, thank you. I think you're still sharing the screen, Nick.
I'm going to unstop the sharing. Do you want any more pictures of Johnny Wilkinson?
Who's that again? I don't recognise the name. That was a great result. Listen, it'd be really interesting later in questions. I'm sure that people please keep firing in the questions, because I'd like to know if Nick's using that in his own practice and what the response has been from that. And we use Sky Gateway in Scotland, Nick, so it'd be interesting whether we can use that privately. So without further ado, moving on, and thanks again for keeping to time, everybody. I'm going to introduce my last speaker. It's Cathy Morrison. Now, Cathy, certainly from a Scottish perspective, but also a UK perspective, a lot of people will know Cathy. She is the working along with Ness as a optometry program director, a co-director there. She's a community IP optometrist, so very much working, in a practice and getting to see the benefits of IP and schemes that we're bringing into Scotland. She also works along with the GOC, certainly I'm on council there, but Cathy works very much in the CET department, looking at approvals, which is changing as we go forward. But she's a very innovative person, and I wanted to invite her along here today with, on behalf of Keeler, really to talk about BIO and a sort of pandemic rethink. So Kathy, you're very welcome and thank you for attending, and I'm looking forward to your presentation.
Hi, Scott. So thanks for asking me. I always like how I never officially agree to these things and then find my name on the advertising material for them already. So before I officially say it, it's all good. It's all good fun. So today, Pandemic Rethink, it is all a bit different. Oh, my screen is not moving along. There we go. It is all a bit different. Well done for getting this far. These things are always weird. You have no idea whether what you're saying is landing well or not, because you're pretty much going to a blank screen. But there's no question that everybody's lives have been impacted by the pandemic, whether that's physical, mental, or financial. I don't know about you, but near enough every patient that comes into my practice at the minute wants to talk about, so how's it been for you and your experience? From our point of view, things certainly look very different. You may have a sign like this on your door, do not enter this practice. We run on a locked door practice at the minute. We are appointment only for pretty much everything. And I now look like this in the practice, which is very different. And that's a massive shift in our profession in terms of culture for infection control and for risk assessment. And obviously Scott said I work in Scotland, although the accent might be slightly deceptive for that the things now, you'll be in Scotland, you're much more familiar with like Health Protection Scotland websites or health education and public health websites now. And also there's been the remobilisation as well of GOS services. To give an example, for communication as well between government and through organisations, in Scotland we have a PCA, Primary Care Amendment. We're on number 17 this year already. And if you go back to 2018, there were 2. So the communication between government and between practitioners has obviously increased significantly. And as eye care professionals, we've had to entirely revisit our practice, and we're now maybe reevaluating our practice. Many more maybe considering additional qualifications. Many people are maybe seeing the advantage of doing IP or how to get involved in share care. And it's certainly been an interesting time of how we examinize, whether that's anterior or posterior. And I hope to share some thoughts kind of on how you can maybe do that. Now, in the strictest time of lockdown, I don't know about you, but I got photographs from many of my friends who had sore eyes. These are all my friends, just not patients, friends who just had sore eyes during lockdown. And quite helpfully and handily, they do quite often like to draw around things. So to show me the problem. Now, on the foreign body, if I couldn't spot that, I would be worrying whether I could actually do my job. Yes, but they're not always as clear. They're fuzzy, and you may have used Zoom to do consultations with patients, may have used Attend Anywhere. Depending again on what you were looking at, you may, depend on whether you were an acute centre or an emergency eye treatment centre, you might have just been managing emergencies over the phone. So again, the one thing I would say about this is sometimes whenever things get sent to you, there's always a GDPR issue. Obviously, as I say, these are all my friends that have sent me things. But best practice is if a patient is sending you thing, is to always use a secure NHS email address if that's possible. And Zoom, to be fair, is a good software to use if you don't have access to nothing else. And it may be a case of you still have patients that are reluctant to attend the practice at the minute, and this may be your only way to do it. Sometimes, like I say, it does take a bit of time to get things right, to get that nice clear image. I don't know how many times I had to phone a patient and go, no, it needs to be clearer. Sometimes it just takes a bit of effort on a 7-year-old to take a nice clear image to show if there's a problem or not. However, it's not always possible. I had a few conversations with patients over the phone, and I got several pictures of some living rooms sent to me instead of eyes. They couldn't quite figure out how to actually take an image. However, back in the practice, this is what I use. It's a great piece of kit. It's the 3-axis universal smartphone adapter by Celestron. We use a practice management system, so there are no images stored in my phone, so no GDPR issues. The one thing I really like about this system is that it's an XYZ adapter, so the 3-axis, so you can move it up, down, laterally, and you can actually move it in and out, so you'll get the exit pupil a lot easier, and it's really good if you're nice and stable. And you can get images like this. This is from 2 weeks ago. This is 48 hours after we have started early Pred 40. This, I'll also categorize that this is his only eye, and he was down to 630. And a week later, this is him back in there on Saturday. He was very worried whether any of the drops had actually got in, because sadly his dog had died this week that he'd had for 18 years. But the eye, he can now see, and he could drive, unfortunately, drive to the vet to put the dog down, unfortunately. But you can see there's fibrinogen, Pred 40, it's a wonder drug. Now, the other thing is, when we're now testing eyes, we're probably all very familiar with this. With steaming, everything steams up, and the colder weather certainly isn't helping. Now, you can help. It can help it whenever you do your Volk. I do Volk primarily. I don't tend to use direct. When I'm doing Volk, you can warm the lenses up. You can try and make sure that they they've got a wire in their nose bridge for and their mask, but it is quite tricky, and things still will steam up, and you might want to think about maybe preferring different lenses simply because of working distance. And I found myself, I was always, my 9 positions of gaze for Volk exam would be done with a digital wide field, but it's got a very short working distance. It's got a working distance of 4 to 5 millimeters, and then I would go back and look at the macula and the disc in each eye with the digital high mag, and that has a much longer working distance of 13. I've actually now, if throughout the test, when I've seen in refraction, we've had massive issues with steaming up of the frames, steaming up of the lenses, I quite often move back to superfield, and just even that extra couple of millimeters actually can make a bit of a difference. It can make things a bit easier, but that's fine for if you can do Volk. What about if you've got one of any of this lot? Okay, now it can be a bit like herding cats for a photo, and it can be a bit like herding cats whenever you're trying to do a fundus exam with somebody like this. We've got my 90, well, she's now 96 and a half, your old Nana in the middle there. She's got osteoporosis. You can see there, she's really short in the body. You're never going to get her on a slit lamp. She's already in a wheelchair, already propped up with 2 cushions on there. And you've also got Mary there at the front trying to make her run for it. So the kids are very mobile. So for that, you need to really think about how you can do the best retinal exam. And I'm not a massive fan of direct. I think the potential of missing, there's a potential of missing a lot with that. So therefore, somebody who's in a wheelchair, complex needs, comorbidities, kids that don't sit still, then I quite often use a binocular indirect. And the one thing I would say is, if you're doing any domiciliary work, this is a no-brainer. This should definitely be part of your kit. I work in the land of hyperopes, accommodative and non-accommodative strabismic kids. I work in Cycloplegic Central. I use Cycloplegia all the time. It makes it so quick to get an image of with a child who is being perhaps uncooperative. Binocular indirect has come a long way from being hardwired into the wall from whenever I was at university. They still, the hardwire ones still work. I will say that, but things have developed and they do get better. So there's 2 things that Keeler have. One is a cordless headset and also a spectacle mounted headset. Both of these are fantastic, really nice pieces of kit. And if you've ever been at anything that I've taught for binocular indirect, I on a workshop, I've taught with the headset primarily. And it's really nice. You can control brightness. There are filters on it. They're adjusted with the, I don't know if my mouse is there coming up, but they're adjusted on the side here. You've got a red free, a white light, a cobalt blue. You can change the size of the aperture. You've got stereo view. It's a really nice piece of kit, and you can move about quite freely with it, and you're not attached to anything. You don't need to worry about whether you're going to take the plug out when you move. The one thing some people ask is about scleral indentation. Leave that to the VR surgeons. I've asked many ophthalmologists, and Sanji may tell me otherwise, but they have always said leave it to the VR surgeons. And that's fine. You can get such a good view and such a quick view with this. And again, there are a plethora of lenses. I think, again, we just get obsessed with using a 20 diopter lens. That's the only thing we ever learned about, maybe at uni, or maybe had access to. And they all have a different field of view, and they all have a different magnification. So just be aware when you're looking at these things, the working distance on these as well, they give you that bit of, if you've had issues, if you've dilated a patient up, and you're having real issues with the lenses steaming up, then you can use like a binocular indirect with a longer working distance lens. The working distances on these lenses, you're not going to be impacted by a lens steaming up. But there are quite significant working differences here. If you look here, a 40 diopter lens has a working distance of 20 millimeters, so 2 centimeters, versus a 14 diopter lens, which has a working distance of 75 millimeters, so 7.5 centimeters. So just be aware that you probably find you have a bit more in and out maybe before you find the image. It is a bit different. You are now the slit lamp when you have this on your head. So there are a bit more moving parts. The patient doesn't have a chin rest, but it is worth it. The lineup can be tricky to achieve, but with practice, you can get the fundus. And as Nick mentioned in Optos, we might not all have the privilege of having access to an Optos to a wide image, but this is great. You can get something really quickly, a field of view really, really quickly. Supine, if you ever see a VR, a vitreal retinal surgeon do this, they often have the patient lying down. And the reason is you can get out far quicker, you can get out much further to the periphery, and especially if you see anybody doing any work with retinopathy or prematurity, you'll see them with that, the patient, well, baby, they'll always be lying down. But again, I've watched a few VR surgeons do this, and the first thing they want to do is the patient in a horizontal position. For wee people, if you've got little people, I had a 2-year-old in last week. If they're really wriggly, really struggling, not that keen on the light, high five. If they put a hand up, high five, that'll get you the disc in the macula pretty quickly, because they don't always want to look at your waving hand, but they quite often want to give you a high five. But again, it's once you have a bit of confidence, then you can get around quite easily with this. Or again, with children, if you even have like a teddy or something that you can hold around. With the lenses, I'm just going to show them up. If you have the lenses, you can see, oh, I don't know what'll come out, but the lens, it's a lot of lenses aren't by aspheric. They're not a double aspheric lens, so you need to make sure that you're holding them the right way. There is a silver ring, but you'll not see that. It's not going to come out in the camera. Right, just about. You can see the glint of the silver. Yeah, the glint of the silver ring. Whereas on the other side, it's just blue. The glint of the silver, that's the direction you hold it to the patient. So field of view, just to kind of finish off with, because you're in tier 4, you've got nothing else better to do on a Saturday night. Why not dilate yourself and show what you can really see? And incidentally, I put this on Instagram last night, and I put it with a vote of whether I had gone mad or whether I was preparing for a talk. 85% of people said I was going mad. So here we go. This is the field of view you can get. And it really does show. This is with this one here is with the clear field. You can get a really good view of the disc and the macula. Now, I'm going to show this because it does show that you do need to work with the working distance a wee bit. And you can see that the manipulation there, if I move this around a wee bit, you'll see that you'll maybe catch like edges of it. Now, again, that's all just to do with practice and tilting, because like a Volk lens, whenever you lose the image, you have to tilt the lens a little bit. So just be aware of that. Now, this was done just with a phone light. And just with the phone light. So this is a monocular indirect, and I'll explain a wee bit about that as well. This is the clear mag, so you can see that the magnification there, you'll get a really nice view of my macula. I was pretty bleached out after this, but you can see the magnification difference there. It's much harder. I tried really hard to get the disc on the macula, but I just couldn't quite get my eye and the focus in the right spot with this one. When you're doing it on yourself, it is harder. But when you do it on somebody else, it is fine. Now, hopefully, this shows you that the field of, the massive improvement with the field of view in comparison to a direct, if you're still utilizing a direct. The 5 degree, you only really have about 5 degrees, you're really going to get the disc. The other thing about the image, it's just like Vogue, it's upside down and back to front. But hopefully we're all okay with that, because we're all pretty much using Vogue a lot more than maybe we previously did. But if you do struggle with that, my tip has always been turn the page upside down, draw what you see, turn it back around. That's what you've got. Okay, so if you're really, really struggling with the perception and things of that. So that's kind of this. I'm just going to say very quickly, this is monocular indirect. You can do this. This is brilliant. I've used this overseas when I've not been able to bring a headset out. And you can use either a direct ophthalmoscope as a light source. And if you put the direct ophthalmoscope on the tip of your nose and point it through the light, that gives you your angle. It works really well. You can use a phone light. The phone lights are brilliant. They are really, really good because they're much, much brighter normally than your direct now. And you can then switch the video on, and then that'll allow you to record. And if you do need to send it on to somebody else, or send it on to give it onto a patient, it's a really good way. Now, you may have access to an arc light or something that Ian Livingston, who's in Scotland, who's massive with teleophthalmology and all these things, been working on. That's great, but this can work as well. So that's kind of me in summary. I just want you to think about, even if you don't want to think about a binocular indirect headset, just even think about expanding your lens kit even as a start. I think we're quite often, and especially we think just generally about the Vogue lenses, but hopefully I've kind of given you an example of how there's other ways to test. And again, give things a go. Scott introduced me for Nez. We actually are really fortunate. We have a VR simulation unit that can demonstrate binocular indirect. Scott's had a go at it in the past. And once we get back up to more face-to-face delivery, again, that's always available in anything that we kind of run at Nez. Okay, so that's me.
Fantastic. I love your self images, but I think you should definitely contact the NES mental health line. Because although you did remind us of when we were students, we did go to people's houses. Douglas Miller just texted me there, a friend, and I remember that we used to draw people's fundus, which took hours and hours and hours. But absolutely, to use this for certainly pediatrics, for ROP, for looking at that disc with 3D, for domiciliary patients for glaucoma. But you're very passionate about it, Kathy, and thanks so much for taking part in the presentation. So really, without further ado, I'd like to move on to all the questions, and we'll be getting lots of great questions in, and we've got lots of great speakers and we can ask them stuff, and that's really what it's about, isn't it? So David, could you put Caroline on, please, because Caroline is going to collate the questions and take it from there.
Hello, good morning. In fact, good afternoon, everyone. Thank you very much for being with us for the last hour and a half. Thank you very much to our amazing speakers and also to the companies that have supported them being there this morning. I think you'll all agree it was a great range of presentations. Yes, I've been collating the questions as we've gone along. I'm not sure if I can allow people individually to speak, but if we can start just with some of the questions that have come in, and then I'll try at the same time to keep looking at what's coming in on the feed on the chats as well for you. So if we can start off with our first question to Dr. Sanjay Mantra. Great presentation, good kickoff to the morning as always, Sanjay. One of the questions that's come up, and it's been something that people have been debating for a while, is about bilateral cataract surgery. Some people like Chris Liu have been in great favour of it from day one. Other people have been a little bit more hesitant, but obviously with technologies moving on, that's shifted. And in addition to that, COVID, as you pointed out yourself, has sort of made people think in different ways. So can we ask you just to expand a little bit on how you feel if I can ask you to go just beyond Scotland, because flicking through the pictures while I've been and names, we actually have people from all 4 nations online, in addition to the Republic of Ireland. So if I can just hand over to you, Sanjay, to just sort of say where you think the future is going to be with bilateral surgery, both privately, which I know is being done quite a lot, certainly here in London, but also maybe through the NHS.
Thanks, Caroline. I think, you divided almost 2 groups where you mentioned Chris Liu, and it's definitely me. I was in the other group. So if you think of the uptake, so they had a major consultation at Royal College of Ophthalmologists just after the pandemic, and Chris Liu was chairing that, and I think they had laypersons, everybody. It was a big representation, and effectively, even now, the uptake of bilateral cataract surgery is only 13%, so it's not a lot. But I do think where people have actually is where the patient needs bilateral. It's probably not done as a shortcut, not just for convenience. So I think I would strongly say that the uptake of the reason being combination of reduced risk of endophthalmitis with better techniques, more options available in the post-pandemic where you're trying to decrease their visits. I do think whether it's any part of the United Kingdom or Ireland, I think the main thing what we are looking at is have very careful selection criteria. So I would not do an 80-year-old with a Fuchs endothelial dystrophy who I think theoretically could have a problem, or I could have a complex surgery or near complex surgery where I would not offer them bilateral surgery, but a standard straightforward cataract where I've decided I'm going to do both eyes and the risks outweigh the benefit in terms of the risk of bilateral. So bilateral endophthalmitis is very, very, very uncommon. If anything, the last 100,000 cases of bilateral that was described, the less than 12 got, but it was unilateral endophthalmitis. So 12 per 100,000 is a very, very small number. So I do think there will be a more uptake, but like everything, like a bilateral surgery for elective condition, I don't think it's naturally in our remit. So we don't generally, so even at Golden Jubilee, where we are actually starting to do this, we are very cautiously going for it. It's prepared in a different way, but that's not the norm. And I don't think it'll replace as a normal part of the surgery for everyone. So I think we'll still have to go carefully on it. But it's definitely going to be on the rise, whether it's NHS or privately. I think it's more about the patient pathway and the risk of them visiting the hospital. But it is a bit of an interim arrangement. I don't think, let's say a vaccination comes and everything is back to normal. And actually, we've now got results of more like 100,000 patients being done in UK. People will get more confidence, but it's a general move rather than a straight move to bilateral surgery straight away.
I mean, there's many reasons, and the patients obviously have to have a decision about that, and they have their own thoughts about what they want done. On average, however, what sort of time lag is there between surgery? I've certainly in practice in London been seeing that time difference coming down much shorter. I mean, obviously it depends how advanced the other cataract is or if it needs to be done, and so many other features. But just in general, if you weren't doing bilateral, what would be the sort of expectation for speaking to patients about how long it might be?
Right. So NHS wise, I think it's very difficult to say because every unit has a different waiting times.
Yeah.
But for anisometropia, somebody high hyperope, high myope, you certainly will do it within 6 to 8 weeks.
Yeah.
But privately, the main reason for, if I was to do bilateral cataract surgery or sequential cataract surgery, the typical waiting is a week for me privately, because the risk of endophthalmitis is maximum in the 48 hours. minimal after 5 days. I'm not saying you don't get it after 5 days, but minimal afterwards. So a typical time privately is a week apart, or 5 to 7 days apart. But NHS wise, it depends on where you're working. But the people who do get a quickly, and I had my practice at Gartnavel for a long time, where if it was a -7 myop, I would actually list them for 6 weeks apart. You can't theoretically put it on a track care or the system that hospital has, that you can't put both eyes together. So you have to do one eye, and the minute you've done that eye, then automatically block something for 6 weeks apart.
Thanks,
okay.
Yeah, certainly, you know, coming up to, there's people on the screen of the same era as me, certainly coming up to nearly 40 years in practice, we obviously are seeing huge differences, and it's really good to keep up with what's happening. There was one particular question which didn't come up on the screen, so I've also been taking questions on phone by text as well. And this is more relevant to people in Scotland, but apparently you've got supplementary code 2.9. Those of us that don't practice in Scotland, perhaps somebody will enlighten us. Kathy's probably in the best situation to do that. And that involves discussing the risks and benefits of surgery with patients before they're actually forwarded. So most of us in England would be doing that anyway, but in Scotland, in addition to the normal fee, there's a supplementary fee for that. Since that came in, have you noticed that the patients have got greater expectations, or is it just patients are more switched on because they look at the internet these days with regards to you know, being prepared for cataract surgery, Sanjay?
Yeah, I think, as you say, the interaction or the shared care model of primary care and secondary care is a lot more sort of advanced in Scotland. And I think you're right. When they come to us, actually, almost the referral will say that they've discussed this, and patients definitely come a lot more informed. They're obviously aware with, and a lot of them will actually come with a patient information sheet, the cataract information sheet, and they've actually made up their mind saying, well, my optometrist says only one eye, and that's what I'm symptomatic about. So they've actually done a bit of research before, and some obviously on top of that would have done, you know, gone to Dr. Google and done their research before they come in. However, most of them are actually quite, which is very useful actually, because I think, you know, as you say, now glaucoma is coming along the way, but for cataract, there's so many practices across Scotland where actually effectively the patients were coming for a consultation, but they were almost ready for surgery, though we don't do one stop, but they were almost ready, and effectively you needed to spend a bit more time going through a bit more surgical complications, an alternative that's available. And but I thought that was quite relevant, that because the risks and discussion are done, I thought it was very relevant in Scotland particularly, where the alternatives are explained to them and lens choices explained to them. Now, don't get me wrong, it's not on the optometrist to say these are the things, but just having the choices available and explaining about unilateral versus bilateral, conservative or surgical option, or types of lens choices is part of the consent process with the Montgomery versus Lanarkshire.
Thank you very much, Sanjay. Could we have Kathy's speaker opened up, please? Or can Kathy open herself up, whatever's happening here?
Yeah, well, there are some one-stop models in Scotland, like Ayrshire and Arran, it has a one-stop model, but yes, the Scottish government are very keen to, and I hate to use the word conversion rate, but they almost have like from a referral to surgery, they are very keen to have over 80% of that. So, you know, the risks should be discussed with the patient prior, and the electronic referral pathway, and some electronic referrals will say has a leaflet about cataract surgery being given to the patient. That actually has to be done in the actual referral, and certain health boards, maybe the same in England for certain trusts, that you have to actually go through those risks and go through that leaflet with them prior to surgery. Most boards will have an example of what they want you to talk about the patient specifically about, So that does happen, and that's where you get the 2.9. I quite often in practice, if they're a wee bit hesitant about it, I'd be like, look, go away, take all the literature with you, talk with your family. I'll phone you in a couple of weeks, or you can phone me. I'll give them that option, and then after that, they come back and they're great. And I see Ross. Yes, I have seen Ross's cataract referral list, repayment list. It's really good. It's a really nice way to kind of go through things, because again, in certain boards, there's obviously there's a fast track procedure for certain people who are fairly straightforward, and then there's ones that are comorbidities that potentially wouldn't be suitable for fast track referral as well.
Thanks very much, Kathy. Yeah, I was actually then going to open up to Nick Rumney and indeed Ross Henderson, because again, Scotland has some fantastic systems. That's why I'm retiring back home, guys, in a couple of years, not to work, just to retire, to be looked after better. But if I can just open Nick Rumney and Ross Henderson with regards to a question Ross brought up between Open Eyes, which I believe is obviously the system a lot of you are working with in Scotland, and the possibility of it working with Harmony. That also might bring Sanjay back in. Can I say at this stage that all these guys speaking today are going to be at our fabulous 2021 conference, where it will give you a lot more time to actually speak to them and these ideas developed further. But if we could have mics opened for Nick and Ross. Maybe Ross to kick off to begin with, because Nick wasn't, I think, aware, based on the question I saw, of Open Eyes. So if we could have just a brief summary of that, that would be lovely, Ross.
Open Eyes is being used by Scottish Government and by the Welsh, some Welsh optometry practices, and also the Welsh Health Service. And so it's being looked at in Scotland. It's at very early stages. It's basically, there's different pathways: medical retina, glaucoma, cataract. So the ophthalmologists are trying to get their heads around using this EPR. And it's just really how Harmony works in with that, and whether it's going to be able to be used with Open Eyes.
I think the simple answer is we don't quite know. I mean, at the moment, as far as I'm aware, there are negotiations with some Welsh health boards about utilising Harmony. So if others are using Open Eyes, the probability is it will be done in some sort of integrated way. I don't think we do integration in England. I think it's just
it's a postcode. It's a postcode lottery.
It's the postcode lottery, and yeah, so much. Mind you, you know, that postcode lottery extends to Amazon Prime, who doesn't think Northern Ireland's in the UK. But never mind, we won't quite go there just yet. So I think the key thing is when you start to use it, it is very manipulable. So we have just started up as a pilot site within the practice. We've linked in with 2 ophthalmologists, one down in Cardiff, one locally. They're both private sector ophthalmologists, and it's just really sort of testing our ability to move quantities of data. At the moment, you know, within our electronic record, we generate a letter and then we pop that into a folder, and then we generate the images, which are usually JPEGs, and we pop that into a folder, and then we go onto NHS Net and we add all those in together, and then we email it into the hospital or into the ophthalmologist, and then at least they've got a line of communication back with us. But they have to assemble all of that together. And I think one of and that's the private sector. The NHS, I've no idea what our local NHS hospital does with our email JPEG images. I suspect they don't print them out and put them in the record. I don't know. And when you go in to do a session within our local NHS, there is nothing electronic. Everything is still in the old-fashioned A4 written files, which are incredibly difficult to find your way through when the patient's got multiple morbidities for different disciplines and different departments to find every single letter. it's incredibly antiquated. So my guess is there's lots of these platforms. They will integrate better than the paper systems we've got at the moment, which don't integrate at all.
Can I come back? I'm going to pick up Sanjay's question, but just before that, Ross, there's been a request if you could share the list. We'll maybe do that offline, but a nice way to do it. Obviously, we're building the website for the relaunch 2021 event in Glasgow next year. It would be a nice piece of information. Most of the people who are here certainly have visited our website, but happy to come up with other ways. Kathy's maybe got some of circulating it as well, but it would be great. But I'll pick up with you outside. I'm very aware I want to speak to the two dry eye people, but before we do that, can I just pick up the question from Sanjay, please?
Hi, Nick, a question for you. Would you want to do a pilot in Scotland?
I'll talk to our Harmony manager. It's a guy called Steve Eaton, who may well be known to many of you as one of Topcon's sales reps, but he's the father figure for Harmony in the UK. So I think it's certainly feasible. Perhaps if you let me know your email address via Caroline, and I'll link you up directly.
Okay.
And I think, we're always at the cutting edge. One of the reasons you come to see us, I hope, every year is because in addition to fabulous speakers and CET, we have a great exhibition. And I was speaking to Nick about Harmony a few weeks ago and realized that it actually came from, as he said, a firm company based, they're now part of Topcon, but based in Oulu in Finland. And they actually 3 years ago were at the conference in Glasgow at the Radisson with their kit. So we'll continue to bring you some great cutting edge stuff in the workshops as well. If I could move on to Nick Atkins, please. That was a bit of a tour de force of everything you've got. One of the questions was about iLux, and I think you already said that there's certainly going to be a webinar with more information on it through the tech bites that you've been running as Positive Impact. And I think, as I said at the start of this is being recorded. I'm not sure when Scott and the gentleman he's been working with in Glasgow are going to get it on the website, but people's slides will be up there. So in other words, the contact information of how to contact people. If any of the speakers want to add any other contact information, re their sponsors, or please feel free to do that as well. And we'll make sure that goes up so people can keep interacted. So iLux is obviously going to be quite soon. The other question somebody had was regards to the Hydromed products and how, if you could use Hydromed 40 and Hydromed with contact lenses. I'll let you take it, and then I'll maybe say what I published in Optician a few months ago, Nick, but I'll let you kick it first.
That's a good question. Caroline, I think you were referring to new lids.
Sorry, new lids.
It's all right. That's
I need
fine.
to get these multifocals. We should have had some of the spectacle people with us today.
The planned launch of new lids will be the new year, January. And as I say, there'll be a bit more information and a bit of a demonstration on the tech bites. With regards to Hydromed, it's an interesting question. Yes, it is. As far as it doesn't have anything in it, it's preservative that will potentially cause any problem with contact lenses. The interesting thing is, being a mucomimetic, one can sort of speculate that the best place to have Hydromed, if you're a contact lens wearer, is actually sandwiched between the contact lens and the corneal surface. In fact, I did a study many years ago that was published in Optician. It was just not a particularly highbrow study. It was a multi-center practice study where we actually got daily disposable wearers to try doing that with their drops, putting Hydromed inside their daily disposable just before they put them in. And the really interesting thing, it was via patient and practitioner questionnaire we developed the data, but we asked comfortable wearing time before the study and comfortable wearing time after using the drops. And typically, the average, I think, comfortable wearing time was, if I remember correctly, was about 11 hours. And after they used Hydromed, they were reporting about 13 hours, so a couple of hours. Now, as I say, it's not the most rigorous of studies, but it's the sort of thing that every practitioner would do. They would ask their patients before and after a therapy as to how much better it is. So the interesting thing for me is not only did it improve initial comfort, which you would expect, but it actually does seem to improve long-term comfort. And I speculate, because I don't know for sure, that it's got something to do with the mucomimetic properties of TSP being sandwiched between the contact lens and the cornea. Long answer to a simple question.
Yeah. One of the things we will put up on the website, probably the other side of Christmas, because I need to get permission from optician, is for the last decade I've been running a dry eye comparison table. It is quite difficult to get the information from some of the suppliers, which is why you have not supplied. Also, in some cases, it's not applicable, but the whole contact lens and drop use is interesting. And sometimes it defaults to can't be used with the lenses, but certainly could be put in prior to the lenses. And that then defaults to the ophthalmology thing of wait 15 minutes. Do we need to wait 15 minutes as far as a dry eye lubricant's concerned before a lens is put in? And as far as I'm aware, and I keep touch with various sort of colleagues who've attended SOC, the TFOS guys that came in 2018, there doesn't seem to be any huge evidence for that, but we'll put that comparison table up. The nice thing is I own the rights to it, so I can update it if companies want to give me any new information. And there's another table going to be published next month on other products. Nick was talking about eye bags, what's the difference between them across companies, foams, Demodex wipes, those sort of things, which no one's done yet. But moving on to Mina, the question that came up on the chat was regarding which order, why would you use particular products such as, now they're looking at the three, the higher back, the Talos and the Talos Duo. My understanding was that it was just higher back and Talos Duo now in the product range, but I'll hand back to you.
Thank you, Caroline. Yes, you're absolutely correct there. So the two main products is higher back, which is, as I mentioned, the second generation. And then you've got the Talos Duo as your third generation. So that, as you saw on the presentation, I would advise higher back usually for the occasional dry eye patient, but really as a personal opinion, I suffer quite severe dry eye myself. So I would recommend third generation Talos Duo to most of my patients. I would say all dry eye patients. You know, it's a hypertonic drop, it's long lasting, it's preservative free. And, you know, patients that get dry eye, they get on this merry-go-round, as most of us have seen, that vicious cycle. And there's lots of different components happening when this patient is going round and round. So you've got things like hyperosmolarity issues, you've got changes in the tear film. And for me, I think Talos Duo really does help with all of these. And the aim is to really getting them off this merry-go-round and really maintaining that dry eye. So that would be the main differences between higher back and the Talos Duo for me.
The product that wasn't featured, which I use quite a lot of, rather than necessarily using the sort of standard NHS in England Lacrolube, is Talos Duo Gel. That tends to be quite useful for people in the evening, obviously, and most obviously contact lens wearers using that prior to going to bed after lid hygiene. Do you want to let the audience know a little bit more about that product?
Yeah, sure. So yeah, absolutely. So in addition to the Talos Duo, which is in the bottle format, we've also got Talos Duo unit doses and then Talos Duo Gel. So the difference being with the gel, it's got the carbomer in it, so you can apply it, as you mentioned, Caroline, in the evenings when they want that sort of long-lasting effect, especially when before they're going to bed, because again of the viscosity issue that, as I mentioned before. So absolutely, there's those two extra products. Again, really good for your occasional wearers, and can obviously the unit dose Talos Duo can be used with contact lenses.
And the other question, which Nick will pick Nick up on as well, because hopefully Craig Wilcox will be with us. He's spoken before. He's got his own practice then in the south of England, South Coast, and developed a lot of products. So can we just touch on Demodex? I think the question came in from Sanjay, or there was sort of somewhere along the line, there was a discussion about what is the sort of prevalence of Demodex in the population. General population, first of all, would be useful, but also the population that are liable to go and see Sanjay from the point of view of cataract surgery that we've been talking about today. So it was very much a buzz word. Probably 18 months ago now, COVID sort of overtaken some of those things, but just some thoughts if you want to start off, Mina, and then you could follow through, please, Nick.
Yeah, sure. So as an average, it is 40%, but actually the prevalence does really increase with age. So you're getting 100% prevalence over the age of 70. So Sanjay seeing some of these patients, and also over the age of 65 is 84%. So we can see that this is why it's so important to be able to recognize Demodex as, how do we pick them up in practice? For me, seeing the patients that I see, if you've given them some form of Blefaclin, Blefasol, it hasn't worked, it could well be that these patients are suffering from Demodex. So have a look at the increased risk factors, age being one of them, things like if they have, if they're local or immune systems being compromised, any hygiene issues, any pH levels. So you might see a link with acne rosacea and Demodex as well. That's common. But again, this is where, if you do want to get in touch with us, we've got an array of a portfolio which shows case studies how we've picked up Demodex and really how we've managed them with our Blefa Demodex product.
And over to Nick, please.
I can't really add much. Mina knows her stuff. So there's, I haven't got a lot to add to that particularly. Obviously, I think the key thing that people are talking about is the use of tea tree oil, and I'd just reiterate, as I'm sure Mina would, that you don't want to be using just random tea tree oil. I know Craig spent a long time working on formulations with the key active T40 in varying concentrations to work out exactly what formula he needed for the product in his practice. When he developed it, there was nothing around, which is why he did. And subsequently, as I say, we're commercializing it for him.
Currently, I think the current spreadsheet just heading to optician on Monday for publication has got 14 Demodex lid products on it. So they have evolved quite significantly since we had the first couple, say no more than 2 years ago, probably those first ones hit the market. So another great workshop at SOC 2021 is a home and away workshop, what people can do in their homes to maintain both MGD and Demodex, but also what you can do as in-practice treatments as well. Sanjay, did that answer your question? And do you have any thoughts about people turning up? I noticed, I think you said 5 days some clinics might use. And then Mina's comment was that the Demodex might last longer for that. So maybe we just need an education thing going out about how long the wipes might need to be used for.
No, that's a fair point, actually, and thank you for updating that, Mina. I do think, by and large, the prevalence is quite significantly varies from 35% to 100%, as you said, and I think that was the commonest reason we used to get cancellations. But actually, with our supplementary and the referral pathway, most actually have some form of lid hygiene or Blefa wipes using before they go for surgery. So that's almost part of our protocol. But that's a very important point, that if they've not responded, there are a few things on the market about Demodex. So thank you for that.
Okay, And looking at the time and aware that everyone's bearing with us most of the morning, can I go back to Kathy in regards to her actual presentation rather than putting her in the spot with NHS Scotland? And there was a question which has come in with regard, did you recommend 5 degrees separation between light source and viewing angle? I.e., if the light source at the tip of the nose, eye is viewing angle, and lens appropriate working distance. You're probably easier to read that one yourself on the chat.
No, I can see
You've
it,
seen it, darling. Okay, can I let you take that one on, please?
Okay, so the 5 degrees was actually the field of view that you get with a direct ophthalmoscope versus what you would get with an indirect. So you just are going to see the disc. But you're right. So that it's just about having a line and making sure you have that line. So if you have it at the tip of your nose and you have a gaze down at your right working distance, you're pretty much creating that nice straight line for you. When you have the binocular indirect on, that line's already made for you because you set it all up, you set your PD up, everything's all done there. But if you're doing a monocular indirect, that kind of gives you then that angle and that line down. So the phone again as well, you can use that. It doesn't matter so much, but it's just about making sure then you have a line from your eye light straight through the plane. It's all optics. It's all that geometrical optics that you don't want, that you just want to forget about from like first year at uni. It's all of that, but it does kind of make sense. The other thing is that they've asked about whether you can use a 20 diopter lens if you've no BIO lens available. You can, but the image is not great. It's not well done in terms of the aberrations. It's too small. It's just not a fantastic. You're going to be really restricted by your field of view as well. The size of that lens is what gives you that nice big field of view, and the optics of that lens to knock out all the aberrations of it. That's what gets that nice crisp image. So you'll struggle to do it. Is it possible? Yes. Would I recommend it? No. I would say, honestly, I would look at investing in some binocular indirect lenses. And have a play, if you can have an access to different ones, because certain people will find, because they're different again in size and the working distance, some people just find things more comfortable than others. So if you have an option to kind of have a look with different lenses, it's a really good thing. And again, like your Vogue lenses, you're probably going to have more than, if you're going to use it more regularly, you're going to have more than one in your kit. So does Scott have more than one in his kit? You might have.
I was just going to ask, Kathy, do you use a 30? Because I remember Harry Hammer teaching me with a 30, because it's a bit like using a 90 compared to a 78. And he liked, because you don't need to stretch your hand as much. And he said it was easier for beginners. Have you ever
so the 30, I tend to use the 2 digital ones, to be honest. I use the Clearfield is really good as well. And also, like, we have an old 20 in the practice. It is there, it works, it's really good. And again, yeah, and Nick, the 2.2 pan ret is a great, they all have their advantages and disadvantages depending on what you're wanting to do. What I wanted to show with the Clear Mag though is that the magnification is quite significant. The working distance is a bit longer, but a lot of people are like, oh, I don't like using it because I never see a good image of the disc. It's not big enough, or the macula isn't big enough. I'm not going to spot anything. I'm kind of hoping that I've shown that you can actually spot things a bit easier with that if you have a different magnification.
And on that note, can I once more promote, keep you really busy that day. It'll be the afternoon of workshops, Kathy. 4 of them running every hour. Yeah, get some friends to come along. That's one of the key workshops Keeler are going to be supporting SOC 2021. I'd just like to take this opportunity to thank all our speakers this morning. And I'm not suggesting people put their mics back on, but Lynn McLaren's got it. Can we all give them a virtual hand clap? And to yourselves for staying with us. I've got a couple of announcements and then I promise it's lunchtime. So if we could have the last slide up, please, which is the holding slide with the magic new date. That's the virtual. Can I have the second slide, please?
Yep.
Lovely. So please save this date. I do know we've been telling you, and I do need to get back to lots of people after today and say the April date that we were talking about just no longer looks to be feasible. So you know what, we're going back to our diary date. We've been here since 2014. Let's keep it where we're at the moment. Let's stay with our usual Sunday in Glasgow, Radisson Blu Hotel. The information will be up shortly on the website of all the fabulous sessions, not just from the amazing 5 platinum sponsors you've heard from today, but a range of other sponsors. Those sponsors will include from the spectacle lens and spectacle frame industry, doing some really great innovative stuff. Contact lens sponsors who come year on year talking about new developments in myopia control, but also other new advances in contact lenses, some great debates going on, some new technology with regarding macular surgery, and also treatment of dry AMD. So watch this space, keep on with the website. Thank you all, Scott and I, today. It was great to see so many of you, and we'll try and get back to as many of you as possible on that chat feed with questions you had. So enjoy the rest of Sunday. It's very sunny and lovely here in London, and go have lunch with your family. Bye for now.